The last, we move the last speaker. I would like to invite Dr. Henry Chui Callan with the topic interesting imaging guided PCI case sharing, please.
Thank you very much for your kind introduction, and thanks for having me to share with you some of the uncommon but interesting imaging guide PCI cases. So I have nothing to disclose. And my first patient is a 69 years old, hypertension, impaired fasting glucose, hyperlipidemia, complaining of on and on exertional chest pain for a year. And EKG show a Q wave over V1 to 3, and echo show a ejection fraction of 40, akinetic mid to apical anterior septum, and he was clinically admitted for coronary angiogram, and this is the angiogram. So you can see the proximal AD with maybe 50% stenosis. So we actually proceed to do functional studies. The rest of the coronary circumflex and also the RC are normal. So actually the RFR is only 0.82, so it's functionally significant. So we did the OCT imaging for the proximal AD, and this is the angiogram. This is OCT. So you can see some of the honeycombing appearance in the LAD. So it's basically a case of probably a recanalized CTO or thrombus. So this is the still images. So we actually put in one DES, and we did not repeat the post RFR, but I think there is a good stand expansion and apposition of the stand. So we leave the result as such. So they stand land right at the ostium of the LAD. So second case is a 70 years old history of Sjogren syndrome, gastric ulcers, hypertension. He was admitted for anterior STEMI, and we proceed to primary PCI. So this is the angiogram. The right coronary show quite a lot of aneurysm formation in the mid segment. Is a dominant RCA, but there's no significant stenosis. But what you can see here is actually a distal left main critical stenosis with TIMI tooth row in the 1 to 2 row in the LAD, and also the circumflex. And there's also some aneurysmal change in the LAD. This is after we wire and some contrast test, and we actually do the IFAS. This is not the OCT, but they inject contrast in this view. You can see a lot of aneurysmal changes in the LAD. This is after some ballooning, and then we do the IFAS. So we wire the circumflex to protect the cert. This is a non-dom cert. So this is the IFAS. I will play it a few times so that you can see. It's quite an uncommon IFAS imaging. I will go through it. I will go through with you slowly. So this IFAS, initially there's media, but you can't see any media in the mid LAD segment. And there's the adventitia layer is very abnormal. It's a lot of tissue infiltration in the adventitia. There's some calcified plaque in the more proximal LAD, and also the left main. So basically, you don't see the media. There's a media destruction indicating some inflammatory or vasculitis happening, and the adventitia layer is very thickened. So this is actually implying one disease. But anyway, this you can't see the. This is the adventitia layer, point by the pointer, and you can't actually identify the media layer in this IFAS imaging. You see some of the calcium at 1 to 3 o'clock, and this is some of the plaque, but actually the media is destroyed in this vessel. So it's quite atypical of a aneurysm because because the adventitial layer is quite thickened, it's indicating some infiltrative disease, and we have some more investigation later on. But we have to manage the patient STEMI first. We put in stent in left main to LAD, and this is the final angiogram. We don't touch the aneurysmal segment in the mid LAD. So we go back to do the eye first after the PCI. You can see some of the aneurysm in the circumflex territory. We do the PET-CT in this case. Basically, there's a multiple lobulated enhancing mass along the three coronary artery with coronary calcification and narrowing. So underlying disease like vasculitis, periaortitis, pseudotumor, etc., has to be considered. So it's actually a case of IgG4 disease. It is increasingly recognized recently. We checked the IgG4 is elevated, and this patient was treated with a systemic steroid, and actually the IgG4 level dropped to normal. And IgG4 disease, coronary involvement could cause either stenosis, aneurysm, and also wall thickening, as in this case, with IVUS imaging characteristic of media destruction and also adventitial layer thickening. So this is one of the case report from, not from me, but you can see actually from CT coronary angiogram, you can see abnormal thickened adventitial layers due to tissue infiltration. So we actually managed to did a follow-up angiogram 2 years later, and still the aneurysm in the RCA, and you still have the aneurysmal changes in the LAD, but in the delay imaging, you can see some of the myocardial brushing in the mid-LAD because of the adventitial layers is heavily infiltrated by some of the tissues. Circumflex CTO, but small, we don't want to do because it's a small territory and probably not beneficial to do this complex small territory CTOs in circumflex. So this is, and a third case is a patient with 79 years old, hypertension, diabetes, sigmoid with atrial fibrillation, admitted for sudden chest pain and confusion. And ECG show a ST elevation over AVR and also diffuse ST depression in the other leaks, suggestive of the left main involvement. So this is the angiogram. And you can see actually there's a quite long left main, and the left main is actually smaller than the LAD. So it means that the left main is actually having problem. And usually the left main would be bigger than the third and LAD. So you see actually the left main is smaller than the mid LAD. This is clearly abnormal. Although there's a timid free flow. This is the right coronary. This is a dominant RCA system. So we did the IVUS. So this is the IVUS imaging. So coming from the LAD, so it's a normal. You can see is the circumflex, some calcified plaque. Sorry, this one is the circumflex. And you can see some of the hematoma in the left main. At the actually, this is the hematoma in the left main, originating from the aorta. So actually, this is a case of intramural hematoma. Actually, type A intramural hematoma or dissection. You don't know from IVUS imaging. You need to do other imaging modalities such as CT. And this is a type A intramural hematoma, actually extending into the left main. And I think we have thought of some rather whether we stent the left main and then consult the surgeon, whether we off table do the CT and then consult the surgeon. But in their end, we choose the second option. But maybe the wiser option would be to stent the left main first to stabilize the patient, because the ECG is so ischemic, and patient is also having an ongoing chest pain. So perhaps stent the left main to stabilize the patient first, and then go for CT and then consult a surgeon would be the better option. But anyway, we don't know whether it's a type A dissection or IMH, but still you can stent the left main, and then you can ask the surgeon to repair the aorta later on. So the CT found that this patient is having actually a type A IMH, which extended into the left main, causing a critical stenosis in the left main. And basically, the IFUS cannot show cut that is really critical, but you can see actually on some of the IFUS CT imaging reconstruction that actually the imaging at the left main ostium is quite compromised. So that's why the patient was so ischemic with the ECG showing left main pattern. Patient actually deteriorate after the CT and succumb after that and cannot do the surgery. But probably the better option would be stent the left main and then do the CT and ask the surgeon to do the type A dissection repair rather than sending a patient to the CT. So this is the last case I have: hypertension, hyperlipidemia, gout, uh, some coronary fistula, normal left main, proximal LED fistula to PA, proximal RCA also fistula to the PA, and there's diffuse RCA disease from proximal 70%, mid to distal 80%, and also the PLV branch. So we finished calling the RCA, and then we do the stenting to the mid to the RCA from proximal to the distal. So we call all the fistula, and then we proceed to the PCI. It's quite torturous. So we decided to do the DCB of the PLV branch and then stent from the distal RCA right at the bifurcation all the way back to the ostium of the RCA. So this is the first stent, second and the third stent. So this is the final results. So I think there's some distal stent edge dissection, but we felt at that point that the dissection is not severe and maybe caused by the DCB, so we decided to leave because of the TB3 fault initially. Actually, we have the IFUS, and you can have a look. This is the IFUS after the stenting. So for the sake of time, perhaps I will show you what is found in this IFUS. It's basically in the distal edge. There's some media the media layer is actually got torn apart. So this is the media layer outlined by the red circle. Actually, in the stent edge, the media is being tear with some of the hematoma formation. So I will show you once more this. Pay attention to here. There's a media layer tear at 5 o'clock. And this is very important to recognize because on angiogram it look fine, but sometime on IFUS, if you got hematoma formation, this is the time you need to put in another stent. Stent edge dissection is different from DCB dissection. I mean the POBA dissection. Stent edge dissection you probably need to cover, especially if there's a hematoma, especially the media is being torn apart. So we actually did not put in the stent. Uh, then patient after a few hours to the floor complain of increasing chest pain with stent thrombosis. And I knew this is a case of dense edge dissection causing the problem. So I actually popped a contrast and found that the distal RCA is occluded. I wire, you can see some contrast staining in the distal RCA. And then I do the IFUS. This is the IFUS. So you can see this is a hematoma because of the contrast if replacing the blood. So it's a big hematoma in the distal, so causing the hematoma formation and because of the media tear. And we put in another stent. This is the result after doing the uh, another stent in the distal segment. So because of the time, I will jump to the conclusion. So physiology is useful to guide when and where to treat. Imaging is useful in procedure planning and also post-stenting assessment. Imaging can also help to identify some of the uncommon etiology of ACS, and patient outcome will change only if you use imaging and make correct interpretation and know when to alter the treatment strategy according to the imaging findings. And practice make perfect. and learn from more from some of the case sharing would also help. Thank you so much for your kind attention.
Thank you for wonderful cases and very interesting imagings. Yes, are there question and comment from panelists or audience?
The usual frequently I saw some coronary aneurysm. So what is your antithrombotic therapy for such a patient? Antiplatelet or the anticoagulation?
We just because of the STEMI presentation, we just keep DEP for 1 year, and then we keep only aspirin. But we use a systemic steroid to treat the underlying IgG4. And after the treatment of the steroid, actually the IgG4 level got normalized, but the coronary aneurysm remain unchanged because perhaps damage has already been done. And I don't know whether we should anticoagulate or we should continue that for lifelong. But in this case, it's not like the aneurysm thrombosis. So we also think that steroid has treated the underlying IgG4. So we decide only to keep the depth for 1 year instead of prolong it to lifelong. Thank you so much.
Okay, I think we near to the opening ceremony, so we need to close the first session with the topic, imaging and physiology guided PCI. Nowadays, the interventionist do the PCI. We need the optimal PCI. We need the important role of the imaging and the physiology. And we hear today the fourth presentation from the speaker. We talk about the role of the imaging and physiology, and some of the discussion very excellent from the panelists and from Florian. Thank you so much for all speakers, all panelists. And by now we give for the opening ceremony. Thank you so much.